Elisabeth or Lisa Diver, and we'll just let her take it away. You're on mute. You're on mute, Lisa.
And can you hear me now?
Yep.
Great. Okay, cool. Well, thanks so much for having me. This has been an awesome day. I was privileged to get to hear a bunch of the talks earlier in the day as well, and to be here for Dr. Drigo and Dr. Lakui's talks, as they are wonderfully respected and esteemed colleagues. So I'm going to try to wrap up the sex-specific gynecologic talk with endometrial cancer, latest in prevention and treatment. And I will preface this by saying that this talk is relevant to anyone with a uterus. I will use the term women frequently in this talk because that's what's quoted largely in the literature, but it is important to know that anyone with a uterus can get endometrial cancer. And so all of this data would apply. Not letting me advance, so let me see if I can. There we go. All right, here are my disclosures for some research work that I do. All right, so today I'm hoping that I can improve your understanding of the pathology, epidemiology, and treatment of endometrial cancer, as well as learn about the new and exciting role of immunotherapy in this disease. So we'll go through endometrial cancer background. What is it? Why do people get it? Do we know? We'll talk about both the clinical classification of endometrial cancer as well as the molecular classification, which we're increasingly using to define treatment. And then we'll talk about treatment options for endometrial cancer and the role of immunotherapy. So what is endometrial cancer? So endometrial cancer is cancer that arises from the endometrium, which is the name for the lining of the uterus. This is the part of the body that grows and sheds every month with the menses, and where a pregnancy would implant. So the lining of the uterine cavity here. So we heard discussion of the cervix, and we've heard discussion of the ovary and fallopian tubes already. So this time we're talking about the endometrium. There are other cancers of the uterus, of the wall or the body of the uterus, as well as of pregnancy tissue itself. I'm not going to address those. So if I refer to uterine cancer here, I'm talking about endometrial cancer. So endometrial cancer is a disease that tends to present early and frequently be curable with surgery or a small amount of adjuvant therapy, meaning treatment after surgery, when this disease is diagnosed. However, for advanced stage disease or recurrent disease, treatment options are somewhat limited, and we're really excited that new treatment with immunotherapy is providing new hope for our patients. And I think it's important to understand risk factors to try to prevent these advanced stage patients and see if we can catch this early. So endometrial cancer is the 6th leading cause of cancer death in women in the United States, with an estimated 12,000 deaths last year. So that makes it not quite as deadly as ovarian cancer. It's the 2nd most deadly GYN cancer in the United States. There's about a 2.8% overall lifetime risk of uterine cancer in the United States, which makes it the most common GYN malignancy that we see in this country. The vast majority of endometrial cancer is sporadic, meaning that people don't inherit any predisposition to the cancer in their genes, the cells throughout their whole body. But about 10% of these cancers, and possibly more as our understanding is increasing, does seem to be hereditary, meaning that women or patients with a uterus are inheriting these mutations that make them much more likely to develop an endometrial cancer. And the best known of these are the Lynch syndrome patients and the Cowden syndrome patients. So these are patients who have potentially cancer histories in their family and are much more likely to develop endometrial cancer. So how is it diagnosed? Well, the vast majority of endometrial cancer is diagnosed with abnormal bleeding or postmenopausal bleeding, meaning bleeding from the vagina after menopause. So if I could have like one public service announcement, it would be that bleeding after menopause is never normal and you need to present to a gynecologist for evaluation. Postmenopausal bleeding makes up about 5% of outpatient gynecology consult visits. And of these patients who present for postmenopausal bleeding, about 10% of them will end up having endometrial cancer. So most postmenopausal bleeding is not cancer, but a significant enough percentage of it is such that it's definitely worth getting checked out. And depending on risk factors, which we'll go through a little bit more, some patients are even much more likely to have a cancer if they present with this symptom. For example, patients who are over 70 who have never been pregnant, who also have diabetes, walking into a gynecologist's office with postmenopausal bleeding have almost a 90% risk that they have a precancer or cancer of the endometrium. This is typically diagnosed with an endometrial biopsy, where we take a small straw biopsy pipelle like this. It's about the width of the end of a ballpoint pen. And we introduce this in the office into the cavity of the uterus, the endometrium, and take a small sample of the tissue to look at under the microscope. It's a quick office procedure, and it has good diagnostic accuracy, so it's worth presenting to get checked out. So what about screening? A screening test is like a pap smear, something that we use in asymptomatic patients to try to diagnose a cancer or a precancer. And unfortunately for endometrial cancer, even though it tends to present at an early stage, we don't have any good screening for this disease. And so it's important that we can identify patients who have endometrial cancer by symptoms early in their course. One exception to this is those patients with known Lynch syndrome or Cowden syndrome, genetic predisposition to endometrial cancer, who can undergo screening and risk-reducing surgery. So endometrial cancer, unlike some other cancers and unlike the other gynecologic cancers you've heard about today, is actually on the rise in the United States. So this is data from 10 years apart. And what you can see here is that while it still remains number 4 on the common cancers list in women in the US, uterine corpus cancer, meaning body of the uterus, that excludes the cervix, went from about 39,000 cases in 2007 to 61,000 cases in 2017 and is continuing to rise. So this is perplexing and obviously problematic, as though we can cure many women with endometrial cancer. As you heard, approximately 12,000 women in the US still die every year from this disease, and so we want to help prevent that. So who's at risk and what can we do about this? Well, endometrial cancer has some risk factors, but we don't have a clear cause for the vast majority of these cancers, particularly the sporadic or non-hereditary cancers. So many of these are related to what we call unopposed estrogen, which can be in the context of your body or therapy. So unopposed estrogen therapy means a patient is taking an estrogen without a progestin, and estrogen stimulates the lining of the uterus, which if it overstimulates could lead to a cancer. Progesterones, in contrast, inhibit the lining of the uterus, and so taking an estrogen without the progesterone for that check and balance can increase your risk for endometrial cancer. Tamoxifen therapy also increases the risk for endometrial cancer due to a similar estrogen-like stimulation effect on the endometrium. Similarly, factors in a patient's reproductive life also can lead to this increased risk for endometrial cancer, such as going into menopause late, never having a pregnancy, or having a pregnancy only earlier in life. These allow for more time without those high progestins that are secreted in pregnancy to help reduce the risk, we think is the reason for these risk factors being in play. Importantly, obesity is a major risk factor in the United States particularly, and we think that this is part of why endometrial cancer may be on the rise. Our fat cells make a type of estrogen, and so they can lead to some of this unopposed estrogen stimulation of the endometrium, and we think that this is why this is such a potent risk factor, particularly women with diabetes and obesity for endometrial cancer. But unfortunately, this doesn't tell the whole story. And in endometrial cancer, historically, we talked about sort of this clinical divide of type 1 cancers and type 2 cancers. So type 1 cancers are endometrioid types, meaning they look like the endometrium. That's what that means. They tend to be this classic type that I've just been explaining to you the risk factors for, associated with estrogen exposure and obesity. They're more common in a slightly younger perimenopausal age range. They frequently have hormone receptors on the surface of the cells, which help to drive or inhibit their growth. And they tend to be more likely to present at an early stage before they've escaped the uterus and have a more favorable prognosis. They also have what we think is a known precursor lesion, which is called complex atypical hyperplasia, where the cells of the lining of the endometrium start to become abnormal, but haven't yet fully achieved all of the characteristics that make them cancer. Sometimes this can also cause bleeding and lead to early diagnosis and detection of this. Type 2, alternatively, are different types of endometrial cancers. These include endometrial cancers that we call non-endometrioid, or like in this picture, they don't look like the endometrium classically under the microscope. These include types that are called serous, clear cell, and carcinosarcoma, as well as some of the higher grade, meaning more abnormal, endometrioid type tumors. The patients who get these tend to be older. These tumors don't tend to be associated with higher BMIs or with exogenous hormone exposure. They're more common in Black women, and they carry a much poorer prognosis and a higher likelihood that they have already metastasized at the time of diagnosis. So this divide is important because on the left, we're looking at a pie chart of the proportion of endometrial cancers. So as you can see, about 3/4 of them make up this low-grade endometrioid type. That's this gray chunk. These are the low-risk, better prognosis lesions, and only about 1/4 to 1/3 are made up of these higher risk or type 2 lesions. If you look at the pie chart on the right, though, which is cancer deaths, you can see that the contrast is true. About 3/4 now of endometrial cancer-related deaths are from tumors that are these type 2 lesions, the higher risk lesions, and only about 1/4 are these sort of lower risk lesions, or the type 1 cancers. And you can see particularly the difference in, this is the serous type cancers. Uterine serous cancer makes up only about 10% of endometrial cancer, but accounts for almost 40% of endometrial cancer death. This is important because recently there's been an increasing amount of research and understanding of racial disparities in endometrial cancer. So in this study, which looked at a large cohort of data over the past 20 years, you can see that in white patients on the top versus Black patients on the bottom, and young patients on the left versus white patients on the right, that there is both in younger patients, but particularly in older patients, a dramatically increased burden of endometrial cancer made up by these higher risk or type 2 cancers. And as we said, these are the higher risk cancers that tend to have a worse prognosis. That doesn't tell the whole story, though. So white women have more endometrial cancer than Black women, but Black women have higher mortality from endometrial cancer than white women. Actually, Black women are twice as likely. And cancer for cancer, accounting for these differences in cancer types, are 26% more likely to die from their endometrial cancer than their white counterparts. We don't entirely understand why this is true. What you can see on the right is the endometrioid cancers here on the left in a younger cohort versus an older cohort, and a non-endometrioid cohort on the right, younger versus older. And you can see that in all 4 of these groups, this is survival, that white patients survive better than their Black counterparts in every cohort by age and by type of disease. Additionally, in the figure on the bottom, this is looking at 5-year survival of non-Hispanic white, non-Hispanic Black, Hispanic, and Asian women with endometrial cancer, with localized disease, regionally spread disease, and distantly metastatic disease at the time of diagnosis. And what you can see is that no matter how or what stage the cancer presents, the non-Hispanic Black women have a worse 5-year survival compared to the other racial and ethnic groups. So we don't typically talk about endometrial cancer as type 1 and type 2 so much anymore. Thanks to the Cancer Genome Atlas, we now refer to endometrial cancer by its molecular subtype, which largely divides into 4 categories. The 4 categories can be seen here, and these are the POL-E ultra-mutated tumors, the microsatellite instability tumors, which are hypermutated, the copy number high, or the serous-like tumors, which are defined largely by p53 mutations, which is a well-known cancer mutation that's associated with poor prognosis in endometrial cancer, and the copy number low tumors, which are generally the classic type 1 lower risk tumors that don't fit molecularly into the other 3 categories. And interestingly, when we look at these categories, we see that they're related to mortality. So the POL-E ultra-mutated tumors, despite we have no data here about the stage of the cancer or anything like that, they tend to nearly universally survive. The serous-like tumors, we know those higher risk tumors, as you can see, do much worse than the other tumors which fall out in the middle. And this has ramifications for how we treat our patients. And actually, current clinical study now is looking at potentially treating women differently based on the endometrial classifications of their tumors. So we're really excited that molecular diagnostics are coming into gynecologic oncology in this space, because this is relatively new in our disease sites. Unfortunately, this only gives us more understanding of the racial disparities in endometrial cancer. So in this study, this was a subset of the TCGA analysis, and these are looking at different types of molecular mutations and signatures that are associated with worse prognosis in younger versus older, white versus Black women. And what you can see is that, again, in the younger patients and in the older patients, that Black women are more likely to have tumors that harbor these high-risk mutations. I think that this is going to help us understand how we can potentially triage patients better and make sure that we can provide better care, so that we as physicians can utilize our knowledge and experience to try to close some of these gaps. Okay, so let's talk a little bit about treatment. So surgery is the mainstay of treatment for local and regionally advanced endometrial cancer, as well as for some distant spread of disease. So surgery includes removal of the uterus with the cervix and the fallopian tubes and ovaries, as you can see here. This is the colon on a view of a laparoscopic case, or a minimally invasive surgery with the camera. We do have data that in endometrial cancer, it is safe and equivalent to proceed with a minimally invasive surgery, which can have equivalent cancer outcomes, as well as help reduce morbidity or complications and downsides of surgery. Frequently now, this surgery will also include what's called a sentinel lymph node. And so here we've used a fluorescent green dye to inject and follow the lymphatics to try to find the one lymph node or few lymph nodes that any woman's particular uterus might drain into first, to try to get important diagnostic information about microscopic spread of the cancer. The pathologic results from surgery, or looking at the tissues under the microscope to find out where the cancer cells have spread, define what's called the stage. And like most cancers, endometrial cancer is stage 1 through 4. And as the stage numbers go up, it delineates where the cancer cells have spread further and further from the endometrium where they started. So stage 1 tumors are still confined to the uterus, whereas stage 4 tumors have spread to more distant organs. Endometrial cancer treatment is defined largely by the stage and by the type of tumor under the microscope, those type 1 versus type 2 tumors. And so basically, endometrial cancer treatment might be surgery only, with a high rate of cure for the lowest risk tumors with only observation after surgery, up through some women require a combination of both surgery and radiation afterwards. For recurrent disease, we have a variety of treatment approaches, including chemotherapy, hormonal therapy, targeted therapy, and immune therapy, which we'll talk a little bit about today. So you've heard a little bit about radiation in the cervix cancer talk, and this is what a radiation plan for endometrial cancer might look like. So external beam radiation means sort of lying on a bed in a radiation suite with the radiation beams coming from the outside, external to the body, and aiming based on a very complex plan, individualized for each patient by the radiation oncologist. Frequently for endometrial cancer, though, women receive radiation only to the top of the vagina, which is a common site of recurrence, via what's called brachytherapy, or internal radiation, with a device like this one that's placed into the vagina, so the radiation can be aimed just at the top of the vagina. Postoperative radiation has been shown to decrease recurrence in endometrial cancer. So here, this is increasing recurrence over time, and you can see that the women who received radiation had less recurrent disease at 10 and 15 years than the women who did not have radiation. Unfortunately, radiation has never been shown to improve survival for patients with endometrial cancer. As you can see, these two lines overlap over time. So this decrease in recurrence doesn't translate to an increase in survival, and that has to do with our ability to treat recurrence successfully when it's localized. So for this reason, we have complex, in-depth conversations with our patients about the pros and cons of receiving radiation after surgery for endometrial cancer. Chemotherapy is an important mainstay of treatment, both for advanced stage endometrial cancer and recurrent disease. So the current standard of care chemotherapy for endometrial cancer is a combination of 2 chemos called carboplatin and paclitaxel. These are the same most common drugs that we use for other gynecologic cancers as well. And this was established in the trial you see here, where we compared carbotaxol to an older 3 chemo regimen and showed that the outcomes were the same, but the toxicity was much better. And so ever since this time in 2012, this has been the treatment. Unfortunately, that means since 2012, we haven't really made any progress in terms of changing our initial treatment of advanced or recurrent endometrial cancer. We have, though, made great progress in immune therapy in endometrial cancer. And while it hasn't yet replaced chemotherapy, there are trials in the works that suggest that it might, depending on the outcome. And we're really excited to see what happens. So this is one of the early trials of a drug called pembrolizumab, which is an immune checkpoint inhibitor, PD-1 inhibitor, as you've heard throughout today. And this trial included patients with a whole variety of cancers that harbor microsatellite instability. And you heard that that was one of our 4 cancer genome atlas groups, and endometrial cancer makes up about 30% of endometrial cancers. So endometrial cancer is this teal color, and what you can see in this study is that down is good, tumor shrinking, and up is tumor growing. And you can see, first of all, that most tumors shrank with this treatment, and that many tumors went all the way away, including some of these teal bars that represent endometrial cancer. So this was really exciting. And actually, based on this, pembrolizumab was approved for any solid tumor type that carries microsatellite instability. And so since that time, we've been able to use it for these patients with endometrial cancers that harbor this mutation. But what about patients who don't, right? So the vast majority of endometrial cancer is not microsatellite unstable. It's microsatellite stable, we call it MSS. And so is there a way that we can take those tumors, what we call cold tumors, and make them sensitive to immunotherapy, hot tumors, we call them, like the MSI tumors. And so this is one really exciting study that combined pembrolizumab, that same immune therapy drug, with a small oral targeted therapy called lenvatinib, which inhibits many things, including VEGF, or the way that tumors can help get blood flow. And amazingly, in this study, again, you can see many more tumors down shrinking than up. These are all endometrial cancers. Is that even in the blue or microsatellite stable tumors, we were able to see high numbers of responses. 38% of the tumors shrank in this study, and even when they were microsatellite stable. So that was really promising because it's much better than any recurrent endometrial cancer therapy after carbotaxol that we've had to date. And additionally, what's extra exciting is that some of these patients had very long responses. You can see these are 85, 90 weeks, so coming up 2 years, and they're still, the arrow means they're still on treatment, it's still working. So that's really exciting. Additionally, it seems to work even for those non-endometrioid types. And there were actually 6 women with uterine serous cancer who had a complete response or a disappearance on imaging of their tumor cells with this therapy. And so based on this trial, this combination was approved in endometrial cancer about a year ago now, which is really exciting. And further trials comparing it to chemotherapy to see if it's even better potentially are now ongoing. So we're really excited to see what will happen with this in the future. So to conclude, endometrial cancer is the most common gynecologic cancer in the United States. Most endometrial cancer, fortunately, is diagnosed at an early stage and has a high likelihood of cure. However, risk factors and racial disparities are still poorly but increasingly understood. And it does seem that molecular features of these tumors will drive the future of therapy, and we're all really excited to see where this goes. So I thank you so much for your kind attention, and I'm happy to take any questions if there's time.
Thank you so much, Dr. Diver. So I don't see any questions in the Q&A, but if you want to add them, please do, and we will forward them to Dr. Diver. So I'm going to actually just share my screen and say thank you to that amazing set of gynecological cancer talks. All 3 were fascinating, and really appreciate that. I'm also going to just move us right through. Instead of a stretch break, you can stand up right now if you want to, but we're just going to welcome you right back. So we're actually going to